A very good morning to one and all. On behalf of IAP Digital Media Team, I, Dr. Uttara Mohan, welcome you to day 2 of IAP South Zone Web Conference. We are streaming live on IAP India YouTube channel. I request everyone to subscribe to this channel to get regular notification of our webinars. You can also follow the IAP updates on various social media channels such as Facebook, Twitter, LinkedIn, and Instagram. So now I request Dr. Rajan Samye to please take over.
Yeah, thank you, Uttara. Uh, Welcome all of you for the first National Conference of Indian Association of Physiotherapists, Day 2 conference. It is my special privilege to welcome Dr. Fiddy Davis, the first inaugural speaker of today's program. I'm really proud and privileged to inform you that he's my first cousin. And before I do an official introduction of Fiddy, I thank all the participants and all the members who have been supportive for this particular conference. And I welcome all the participants, and I definitely assure you that it is going to be a very useful program. So to talk about the speaker today, Dr. Fiddy Davis, PT. He is the head of the Center for Sports Science, Medicine and Research and Department of Exercise and Sports Sciences. So he's a Doctor of Philosophy in Sports Medicine from Mahe University. He's a pioneer in biomechanics of sport, athletic shoe-feet interaction, and sports injury risk, designing injury prevention program, and return to sport testing. So these are all the areas in which he is a pioneer. And welcome, Fiddy, and thank you very much for accepting our invitation and joining us. And now it is all yours, Fiddy, the platform, so you can start the session. Thank you.
Thank you very much, Rajan, for a kind introduction. Hello and good morning to all of you. It's a pleasure and privilege for me to be a part of the first web conference of the South Zone or the South Chapter of the Indian Association of Physiotherapists. I really appreciate the organizers for putting together an idea to have a virtual conference for the first time, and also coming up with a contemporary theme, and that is to make people fit so that the pandemic will quit. I think that's a need of the hour, isn't it? Because COVID-19 has pushed us to some unprecedented times. Physiotherapists are not clear with the role that they play. I think this is a much needed topic, and I thank all the participants for choosing to attend the web conference amidst all mishappenings around you. I hope you have the rest of the day well spent. Okay. I was thinking my area of interest, as Rajan said, was return to sport testing, but that is from after an injury. So I was just trying to extrapolate that to return to sport after COVID-19 infection, because that would be contemporary and also will feed in well with the theme of the conference. So whatever I talk today is based on very little information and data that we have. Even the mode of spread of COVID-19 infection is still not clear, because we hear a lot of discordant information from WHO, from local medical bodies. So there is so much we do not know. So whatever I speak is based on the little information that we have, and also drawing some information from the SARS virus, which the world encountered in 2003 and 2004. But as far as the new coronavirus, I think we'll be in a much better position to understand its behavior, its health implications in over a year's time from now. So that is why it's just an attempt to put pieces of puzzle together so that I give the right perspective to physiotherapists. So for the next for the next half an hour, we are going to talk about these. Let me give you a quick overview and the background of the coronavirus and how that can affect health, especially in relation to sport performance and injury prevention. And also, I'll quickly touch upon the return to sport framework. Why do we need after a COVID-19 infection? And also briefly about the effect of COVID-19 on the cardiovascular, respiratory, and musculoskeletal health. And the present RTS framework suggested by the British Journal of Sports Medicine and also from JAMA. And also a brief note on the psychological impact of COVID-19 and sport participation. And with a final message related to injury risk and prevention after they come back from a COVID infection. So the concepts that we are going to discuss today might not be entirely new to you. Maybe for some it may be new, but all these can be applied not only for elite athletes, but even for recreationally active people or people who have been sedentary and want to start exercising. So some of the principles you can use. So even though I say return to sport and training, it doesn't mean only elite athletes. And then finally, towards the end, we may have a brief Q&A session too. Okay, so the COVID-19 disease is caused by the novel coronavirus. We know that. It has wreaked havoc across the planet, isn't it? It was declared a pandemic in March 2020. And the cases are rising in alarming proportions. Okay, India alone has over 45 lakh patients. We have over 70,000 deaths. Okay, we cannot say that we have a very good reporting system. The reporting system is improving all the time, but in spite of that, we have lost 70,000 people. And our healthcare system, which is already frail, has been stretched to its maximum. So I think it's a moment of time before, at least in some of the places, the healthcare system gets overwhelmed and people find their own way of dealing with this. And it has affected every facet of our life. It has affected every discipline. It has affected people in all socioeconomic strata with different ethnic backgrounds. Okay, and sport is not an exception. So the industry of sport also faced a huge challenge in terms of COVID-19. You know, many of the tournaments were cancelled. Okay, players went into hibernation. Okay, the reason why we are talking about sport in COVID-19 is because it is not something that is essential. Okay, it can always be stopped. But please remember, sport is a huge industry, okay, across the globe. And even in India, the industry status for sport was accorded only a little less than 2 years ago. Okay, if this year's IPL was cancelled, okay, it would have incurred a loss of over 3,000 crores for the organizers, for BCCI and the sponsors of IPL. Okay, and if this is the situation that continues, we know that Australia, especially the state of Victoria, is not doing so well. So in case if the India's tour to Australia gets cancelled, the Australian Cricket Board would stand to lose over 175 million Australian dollars. Okay, and the same happened with Wimbledon when it was cancelled about 2 months ago. The organizers lost close to about 150 million sterling pounds. So what that means is, so that there are so many stakeholders involved in the sport industry. Everybody gets a hit, and including athletes. So athletes are ready to come and play, come and train as hard as possible they were doing before. Okay, and the organizers are trying to arrange tournaments. Okay, so because of this, there can be faulty decisions taken for an early return to sport, which can predispose an athlete to increased risk of mortality. And that is precisely the reason why I wanted to talk about return to sport after a COVID infection. But specifically, we all know that the recent reports say that people continue to have persistent symptoms. So they have a COVID infection, they recover from a COVID infection, but there are some symptoms like cough, fatigue, tachycardia, signs like that, keep happening after a few weeks of recovery or into months of recovery. Um, so that is the reason why we have to be careful. Okay, and to make matters worse, not sure if you have heard this news. This is Michael Ojo. Okay, he's a Nigerian-born American basketball player. He represented the Florida State in the NBA. It was exactly 1 month ago, 7th of August. He died collapsing on the court. Okay, and the previous month he was tested positive for coronavirus. Till that point of time, he didn't have any other existing pathology. So the only relevant clinical history he had was a month ago he was tested positive for coronavirus infection. So he recovered. 2 weeks he was in isolation, and then he started training in Serbia, and that is when this happened. Okay, and the autopsy reports, the early autopsy reports show that he had a myocardial inflammation. Okay, very briefly about the pathophysiology of COVID. I'm sure you know about this already. But the entry of the virus is through the angiotensin converting enzyme 2 receptor, and you know that these receptors are there everywhere, with the greatest concentration in the heart, the lungs, the kidneys. Okay, so these are the systems that is affected the worst, and the way how it affects is basically by these 4 mechanisms that you see. One is it has a direct cytotoxic effect. Because it is a pathogen, it can go and kill the cell. Okay, but that seems to be happening only for the vulnerable group, only for people who have a lot of comorbid illness. But the other 3 mechanisms are the most worrying, because that seems to affect people who are younger and do not have any negative or do not have any comorbidities. So one is it down regulates the renin-angiotensin-aldosterone mechanism, and you know that that mechanism is key for maintaining body's fluid and water balance. It's also responsible for the blood pressure regulation in the body and the vascular permeability to prevent extravasation. All these are dependent on the renin-angiotensin-aldosterone mechanism, isn't it? And this seems to down-regulate that, resulting in all cardiac pathologies. And also inside the cell, this is causing endothelial damage, okay, which creates a kind of a prothrombotic milia, which results in thrombus formation, resulting in infarcts, leading to pulmonary embolism, myocardial infarction, one of those. And on the other side, especially in people who have severe symptoms of COVID-19, body has 2 types of immune system, the innate and the acquired immune system. Our innate immune system seems to fight and sometimes react in an exaggerated fashion. So there is a hyperreactivity from our innate immune system, and that creates what is called as a cytokine storm. And these are the reasons how COVID-19 seems to affect all the systems in the body. Even though COVID-19 was considered primarily to be a pathology of the lung and the upper respiratory tract, but of late we know that it has significant extrapulmonary manifestations too. There are so many systems that are affected along with the respiratory system, isn't it? The cardiovascular system, the neurologic system, and people who already have renal diseases, chronic kidney diseases, seem to struggle with this infection. Okay, so gastrointestinal system, skin, and also the neuroendocrine system too. Okay, and this plays a key role. We are not going to go into the details of the neuroendocrine system because I know that we are talking to a group of physios, but if it is a classical sports medicine, I would have touched upon that. But to say that briefly, our endocrine system is very important to maintain thermostasis, isn't it? To maintain the body temperature at a set level during an event, during sport. Especially in endurance sport, it's important that the body's temperature is maintained so that the thermoregulatory strain is lesser. Okay, so that a large portion of our cardiac output goes to the working muscle. And this is the one that prevents us from getting heat-related illness, okay, heat exhaustions, heat strokes. So we do not know. These are early days. So in case if after testing positive for COVID-19, people taking part in marathon, we do not know how they are going to react from a thermoregulatory status standpoint. Okay. So even though it affects all the systems in the body, we are going to concentrate only on the cardiovascular, respiratory, and the musculoskeletal system for today's discussion. Okay. First is the cardiovascular system. It seems to affect the heart through these two mechanisms. Okay, one is by a direct cytotoxic effect on the myocardium, okay, which results in cardiomyopathy. This is similar. So the picture that the cardiologists are saying is it is similar to a dilated cardiomyopathy, okay, which affects the LV systolic function. And also what COVID-19 does is because of the cytokine storm, because of the hyperreactivity of our innate immune system, it seems to cause myocarditis. Okay, and myocarditis is a possibility even with common cold. Okay, so that is why doctors would always advise after a viral infection not to involve in any strenuous sport for 2 weeks. So COVID-19 also seemed to follow the same path. And a good close to about 30% of people who develop COVID-related symptoms appear to have myocarditis. So that is 1 in 3. And this is irrespective of the age. Okay? And this is a worrying sign. Okay, the reason is because myocarditis, maybe in the initial stages, it can be symptomatic, but it can become subclinical soon. So athletes or people who are feeling okay may think that they have completely recovered, and then they start exercising, and before they develop any symptoms, and sometimes it can be untoward and can result in death. So that is why we need to be careful of this myocarditis that people can develop over a period of time. And what another thing that is worrying is some of the recent reports say that even myocarditis is possible even in people who have been asymptomatic during COVID infection. Okay, so these are tough times, okay, for healthcare professionals, for people who have had an infection. There are so many things going behind their head. Okay, and not only the heart, even the vascular system is affected. As I mentioned, the endothelial damage this causes result in a prothrombotic state. So this is similar to the disseminated intravascular coagulation type condition. So that is the picture the coronavirus, novel coronavirus, seems to lead us to. Okay, so but fortunately, to know if the myocardium is involved or if they have a myocarditis, there are a few serum biomarkers available these days, and one of the serum markers that is commonly used is the cardiac troponin, the high sensitivity troponin. So the values of that gives a fair indication of the damage the myocardium has taken because of COVID infection. Okay, respiratory system is the one that we know very well about the effect of coronavirus on the respiratory system. Other than the patchy infiltrates, the classical ground glass appearance, and this seems to be present in about 30% of people. And the problem is 30% of people continue to have this abnormality, this lung abnormality, even after recovery. Okay? Again, people go and visit the doctor only when there is a new symptom that comes, or if they continue to have breathlessness or a chronic cough or a new onset wheeze. Only when they get this, they go and get tested themselves, and then again when they do a chest CT or an X-ray, this is the picture that they may find. But we have some news which can be encouraging for healthcare professionals like us. It doesn't seem to happen with all of them, but it seems to happen in people who have severe disease, and especially when the D-dimer results were positive. We know that the D-dimer results are done to know about the coagulation profile. And the values, when it is more than 500 nanograms per ml, that is when it is a worrying sign. So in case if your athlete or your patient appears to have a higher D-dimer during the time of admission, these are the people we need to be wary of. These are the people we need to keep them under surveillance for a longer period of time. Okay? And for them, if they come up with new onset symptoms or a persistent cough, it's important all the investigations are done. Of course, we cannot do as a physio, but we can send them to a pulmonary physician and then get the tests like chest X-ray and even do a PFT, because some of these lung pathologies reports say that it can be irreversible. So what that means is it can cause a restrictive lung dysfunction type manifestation in a PFT. And the problem with elite athletes is, in case if they have an irreversible lung damage, because their ventilatory rates during exercise can go as high as, say, about 250 liters per minute, they'll have some serious issue. When I say serious issue, a person who can ventilate about 250 liters of air now will have excess work of breathing, isn't it? So those are not good signs. Okay, and as I was telling you, these are some of the most common symptoms that continue to persist even after they recover. Athletes or recreationally active people continue to have, some of them continue to have breathlessness on exertion even 2 months post COVID infection. And then there is a characteristic cough that may or may not be associated with wheeze. People sometimes complain about chest tightness because of the interstitial fibrosis that happen. Okay, so these are the symptoms that physios we need to watch out for. In case if our patients we prescribe exercise come up with these, we need to send them to a pulmonary physician to get the tests done. Okay. And another thing that we need to watch out is new onset symptoms. So that means people were completely okay, or even during COVID infection, they have been asymptomatic. But after recovering from the COVID-19 infection, when they start exercising, new onset asthma-like symptoms, they start having wheezing. And this has been reported from Wuhan. I'm sorry, I forgot to mention the article from where I took this. But I can send the article if you're interested to know about this. So people who have been absolutely asymptomatic before, they didn't have any lung pathology, appear to have a new onset asthma after this. And please remember, among endurance athletes, among long distance runners, swimmers, there is a good proportion of exercise induced asthma in these people, okay, as compared to normal people. Close to 25 to 30% of endurance athletes may have exercise-induced asthma. There are a variety of reasons for exercise-induced asthma in athletes. Some of the reasons that people say is because of the high ventilatory rates when they exercise, and that too over a period of say 90 minutes, 2 hours, like that, there is insensible water loss at the upper respiratory tract, okay, which irritates the airway, which causes a hyperreactive response, causes thickening of the airway walls, resulting in bronchospasm. Okay. On the other side, when they go for a cross-country running, they get exposed to pollens and other allergens which can make them at risk. So already runners, even before the COVID-19 era, were having exercise-induced asthma. And those are the people we need to be careful, and we need to be monitoring them closer. So in case if they have new onset symptoms like this, or if they have an unexplained exhaustion after exercise, which they did not have before, okay, then probably we need to ask them to go to a pulmonary physician, get it tested, and especially the pulmonary function test reports will be of great value to these people. Along with the bronchodilator challenge or the bronchoprovocation test that the physicians do, that will help us gauge how to deal with these type of athletes. Okay, and this is the framework that most of the organizations are suggesting. So how do we take a decision when an athlete is safe to return to sport? So if an athlete was tested positive and let me take you this. And if he's asymptomatic, the doctor advises 2 weeks of rest and an extra 2 weeks of isolation. Okay, once when all these are done, they can gradually resume activity. But in case if they had mild symptoms, which required hospitalization or they spent time in isolation, so initially we advise them to rest and recover. And then in an extra 2 weeks, even after the symptoms subside, we ask them to be in isolation with hardly any exercise. Okay, but after that, it's important we do some investigation, especially the cardiologist might want, and this is only for elite athletes, I'm saying. So when I say elite athletes, it's not the professional athletes. Even recreationally active people taking part in marathons and cross-country runs, even they can be benefited by this algorithm that you see. So the cardiologist might want to do a high sensitivity troponin levels. Usually, as you know, the high sensitivity troponin levels are between 0 and 0.4 nanograms per ml. And usually when it is higher than this, that means the myocardial injury is still there from the COVID-19 infection. And also a 12-lead ECG, a 2D echo to look at the systolic function and the morphology of the myocardium, all those can be studied. And then in case if needed, pulmonary function tests, chest CT, all those can be done before we take the decision. So if the tests continue to be normal, and then they can gradually resume training. But if they have high troponin levels, when it is more than 0.4 nanograms per ml, then we have to follow the myocarditis protocol. The myocarditis protocol, as put forth by the American College of Cardiology along with the American College of Sports Medicine, suggests 3 to 6 months of restriction from any sport participation. So athletes should not return to sport for 3 to 6 months, okay, based on the intensity, based on the severity of the condition. Okay, if they have significant symptoms, so that means they had breathlessness, there was a need for supplementary oxygen, and they were hospitalized. Usually, at the time of hospitalization, high sensitivity troponin levels will be checked. And if they continue to have breathlessness, and cardiac imaging protocols might show LTE enhancements, LGE enhancements. So if these results come out to be normal, after they finish hospitalization, 2 weeks of rest, and again, a cardiac troponin test can be done. Or in case if it has not been done before, it can be redone again, and then they can resume training. But if we find abnormal test results along with the presence of high troponin, then again, all of us are advised to follow the myocarditis return to sport protocol, where there is complete 3 to 6 months of sport cessation and then gradually starting this. Okay, and because we are going to rely on this cardiac troponin, I thought maybe I should talk briefly about troponin. But please remember, troponin is an indicator of myocardial damage, but sometimes this can result just simply from exercise, strenuous exercise done over a period of time, not associated with COVID-19. Suppose if you run a 21K or a marathon, soon after the marathon, when we look at the cardiac troponin levels, it can be higher. The reason is myocardium also undergoes damage when we do strenuous exercise, like the skeletal muscles. Okay? So there is an elevation in the cardiac troponin values, but as you can see, it may be there for about a day, but after a day, it wanes off. Okay? So that is the reason So in case if an athlete has started exercising and then he has symptoms, it's important that the cardiac troponin test is not done soon after the exercise, because this is going to reflect, and it can make us take a faulty decision thinking that there is myocardial damage from COVID-19, and maybe this myocardial damage was only because of the exercise. Okay. And the reason for increased cardiac troponin values with COVID-19 is because of the high volume load that the heart is subjected to during endurance runs, and these are some of the mechanisms. Okay, so this is the return to sport protocol that is followed by the American College of Cardiology and ACSM. So 3 to 6 months of restricted participation, and before they return to sport, the left ventricular systolic function has to return to normal. The serum biomarkers have to get normalized, and on a Holter monitoring, there should be no relevant arrhythmias. But please remember, myocardial injury or myocarditis can have malignant ventricular arrhythmias, and that is the reason why Michael Ojo that we spoke a little while ago, he died because of ventricular arrhythmias. Okay, so they have to have no clinically relevant arrhythmias at least before taking part in sport on a 24-hour Holter monitoring. And also for people who have higher levels of troponin levels and also an LGE enhancement on a cardiac imaging, they need to be on an annual surveillance at least for 2 years. So every 6 months they undergo cardiac imaging to find out if the myocardial injury is getting better. Okay, so annual surveillance is needed for that. The musculoskeletal system is affected, but not as high as the cardiovascular and the respiratory system in terms of prevalence. But a good 25% of people complain of myalgia, and then there is malaise and general weakness. And among this, 20% of people continue to show high levels of creatine kinase levels. Okay, so creatine kinase levels, as you know, is an indicator of skeletal muscle damage. Again, we do not know what is an ideal level, but it has to be, for it to be normal, it is always less than 200. But during the SARS time, some of the sports medicine studies have found on an average about 250 units per liter. Okay, but sometimes the new coronavirus in some people, I was just looking at the recent research report, some of them have even at 1,600 units per liter. But as I told you, these are early days, we don't have enough information to take a call. So that means there is definitely skeletal muscle damage associated with COVID-19 in a small proportion of people. And what's also being recorded is sarcopenia, loss of muscle. And this is a worrying sign, especially for elite athletes, professional athletes. Them losing muscle because of a virus infection is not good, because that's going to affect them in all facets of sport performance, because that is where metabolism happens. So sarcopenia can result in an alteration in the substrates that is utilized for exercise and sport, so which can become predominantly glycolytic from an oxidative metabolism. So then there are a lot of cascade of events. Okay, other than this, their heart is struggling, so they may have reduced VO2 max because of the lung and cardiorespiratory related issues. So, that's not a good sign. So sarcopenia appears to compound this issue. And also another finding that people are noting down is, you know what happens when we train? Okay, fiber types get converted. If not structurally, at least functionally, they get converted. So type 1 fibers can take up the function of type 2B fibers. This seems to be reversing with COVID-19 infection. So that means in elite athletes, type 2B fibers are getting reversed, and then they're looking like type 1 fibers functionally. Yeah, that is not a good sign for people, for athletes involved in power and explosive related events. Again, this is a study not from COVID-19, but from the SARS epidemic that was recorded in 2003, 2004. Even after 4 to 6 months, people who have had a SARS infection, they had 32% reduction in the grip strength in spite of the training that they did, and 13% reduction in the 6-minute walking distance. So that means it affects the muscular fitness and it affects the cardiorespiratory endurance too. Mind you, again, I'm just talking about the SARS, and because homology-wise, SARS and the novel coronavirus appear to be the same, we are trying to draw conclusions from the previous findings. Okay, so we have talked about how COVID can result in increased risk of mortality, but as physios, you might want to know whether they are at increased injury risk when they resume sport. Okay, definitely injury risk is higher, mainly from the muscular fitness related injury risk. Okay, because the fitness would be poor, and when I say the fitness would be poor, fitness inside a gym is different and match fitness is different. Because they don't play enough number of matches, because they don't have enough mileage in their legs before they enter a tournament, there is a high risk of injury because they are not equipped to deal with the match demands. Okay, so we know that during lockdown, athletes are training only inside a gym, inside the house. Okay, but that fitness is completely different from match fitness. Okay, they don't have enough match fitness, so there is definitely a greater likelihood of injury risk. And also, I must mention neuromuscular training deficits because athletes don't move, they haven't played sport. Multidirectional stresses on the joints are not as good as it was before. So because of a faulty neuromuscular coordination, they are at increased risk of acute injuries in sport. And tendon injuries. You know the biology of the tendon to be stronger is when it is repeatedly placed with stresses, isn't it? And that is how tendons become stronger, because collagen synthesis has to happen, and that is how tendons become stronger and more stiffer. So what happens is during lockdown or during an activity where the tendons are not stressed enough, okay, the tendons can fail. Okay, we are already seeing a lot of Achilles tendon injuries when NBA resumed, when National Basketball Association League resumed. There were at least a dozen of tendon injuries, and all related to the Achilles tendon. Okay, and in case if you are dealing with athletes or people who have the O type blood group, we need to be careful because they seem to be at increased risk of tendon injuries. And also, one final concept. One of the factors that can influence injury risk is the training load progression. Okay? Training load progression in the sense because athletes were in hibernation all this while, coaches were not training them, and all of a sudden they have a tournament coming up. Okay, and the tournaments which were postponed before are now rescheduled. Say, for example, the French Open. Okay, French Open should have happened in the month of May, but now it is in the late September is the French Open. So because of the cramped schedule, the training load will not be linear, or the training load will not be in a favorable pattern to prevent injuries. Okay, I'll just take an extra minute to explain this, and this is the last concept that we are going to talk before we wind up this talk. As you can see, this is the training load progression. Okay, training load progression. The training load can be internal and external. External is the amount of time they spend on the field, amount of time they run, the repetitions they did. All these are the external loads. Internal loads are measuring their heart rate. So this is a speed workout schedule that you can see. Let me take you quickly through this. As you can see here, so this is for every week. Okay, so this is a weekly load monitoring graph. So you can see that there is variation every week, but as you go closer and closer, you can see that there is a peak here. isn't it? Okay, so that means from 1 week to another week, there is a big jump. Okay, the reason is, so here somewhere, let me, okay, I'm not able to find the pointer. Anyway, the red box that you see is a peak. So what that means is that week, an athlete has been pushed higher than he was pushed in the previous weeks. And this is called as the acute to chronic workload ratio. Chronic workload ratio is the workload that they have built, say, over a period of 6 weeks. And the acute load is the load that they have done in 1 week. So if you look at the acute to the chronic workload ratio, if there is a peak that you see here, okay, which can be monitored, which should be monitored by any healthcare professional working with athletes, if you see a peak like this, that is not a good sign. Okay, and those are the peaks that result in injuries. Okay. Okay, so how do we know that we are not reaching the peak? This is what we can do. Ideally, this acute to chronic workload ratio has to be between 0.8 to 1.3. When it is more than 1.3, that means the acute load is comparatively higher to the chronic load. So say if it is 1.5, that means you have increased the load by 50% to the chronic load. Okay, they are at increased risk of injury. Then we need to go and tell the coach that probably the next week should be relatively off. But I know that these are difficult times. Athletes want to take part in sport because that is their livelihood, isn't it? Many top tennis players, those who are in the top 200, or football players, because they don't have enough tournaments, they are not getting paid. So they are looking for tournaments and they tend to push themselves more. Okay, so that is why we need to keep a watch over this load monitoring. Psychologically also, athletes are not ready to return to sport for various reasons, isn't it? So some of the factors that can affect is the fear of getting infected, anxiety about recovery, will they recover completely, disturbed sleep, family conflicts, financial issues. All these can demoralize an athlete. So we definitely need the work of a sports psychologist before they return to sport. There are so many things we do not know about this novel coronavirus, isn't it? We do not know when the vaccines will be available, and if the vaccines are available, we do not know it will offer the protection that we are expecting it to offer. Will there be a relapse, or when there is a relapse, will the severity be the same, or it won't be? There are so many questions. So that is why it is not sure if it will ever be a safe time to return to sport. And that is the reason why we have a criteria. And that, if you look at that criteria, it has looked only at the cardiovascular and the respiratory system. It's that we haven't taken the other systems into account. Those are the things we do not know. Okay, so with whatever little we know, this is the best that we could do to follow the RTS framework that we discussed, to make an informed decision whether it is the right time to exercise, right time to take part in sport. So this is just a parting message from me. This season, this year, 2020, I don't think this is a year when you recommend anybody to do intense training. Okay, let alone athletes, even recreationally active people. I think we need to advise them not to do any form of intense training, because intense training creates a window of opportunity for the pathogens to enter the body and can affect. Okay, and COVID-19 can be the pathogen. Okay, so this is that open window theory you might have learned before. After an intense bout of exercise, there is a period of time which can be as high as 3 days, but usually for about 12 to 24 hours is the time where you are at increased risk of developing an infection. Okay, so the take-home message is not to involve in intense training, at least till we get some clarity about how the virus is behaving or whether the vaccine is going to be available. I think I've exceeded my time slightly. Thank you so much for this opportunity once again. And in case if we have time, I'd be happy to answer your questions if you have any.
Yeah, thank you, Fiddy. It was a clean presentation, and
Thank you.
it was very clear. We could understand the basic pathophysiology, and we were able to know about the algorithms. We were knowing all the biomarkers and alarming informations like 1,600 units creatine kinase. So I think it was a very good and clean presentation. Like every participant would have really taken a very good message, and uh, it is like the psychological impact about the influence on the muscular system. And I think like when every system of a person is going to get affected, and really we need to be really cautious in bringing them back to sport. And that's what was the final message. Like so don't go for any intense training in 2020. So that was very good and clear. I think we have not received any questions from the audience. Basically, I think it was point clear. And thank you, Fiddy, for the wonderful presentation. And we will meet in a different platform, and we expect you to continuously support IAP in the future programs also. Thank you.
It'll be my pleasure to.
Thank you, Fiddy.
Thank you very much.
So now we have the next presenter, Dr. Purnima Singh. So she is going to talk today about is aquatic therapy safe in pandemic situation or in this COVID-19 pandemic. So I welcome Dr. Purnima Singh, madam. So I would like
Thank
to tell few words about her. So she is the principal of Hasmet College of Physiotherapy, Bangalore, and she's a certified aqua therapist by IATF Switzerland. So and I think like she's the only person who's certified, internationally certified aqua therapist, and a very senior person. And definitely we are waiting for your session, madam. And I think now it's time that you can take over.
you, Rajan sir. Good morning, one and all. Can you all hear me, sir?
Yes, madam. Yes, yes.
Yeah. Good morning, one and all. Thank you for inviting me for this first conference of IAP, virtual conference of IAP, and I am privileged to be the part of this conference. So my topic today is aquatic therapy safe in COVID-19 pandemic? The outbreak of coronavirus 2019, COVID-19 has created a global health crisis that had an impact on the way we perceive our world and our everyday lives. And it's and greatest challenge we have faced since World War II. Since its emergence in Asia last year, the virus has spread to every continent except Antarctica. Not only the rate of contagion and patterns of transmission threatens our sense of agency, but the safety measures put in place to contain the spread of the virus by refraining them doing what is inherently human, which is to find solace in the company of others. Yes, I am talking about social distancing. And with the respect to our profession, where we require to be in close contact with the patient, within this context of physical threat, social and physical distancing, as well as public alarm, how can we come out victorious taking care of our patient efficiently? Part of the challenge is to continue to provide necessary clinical care in a safe manner, or for all physiotherapists as well as patients and the community. So, and by following the general recommendations of the WHO. There only came the role of digital physical therapy. And we started using digital physical therapy in the form of telehealth and more specifically teleconsultation, teleconsulting, telemonitoring, which offers the possibility to continue providing some physical therapy services to patients. But what about aqua therapy? Aqua therapy can't be given uh, uh, through physical therapy. So their therapist has to go inside the water and to be in close contact with the patient. So how can we do aqua therapy in during this pandemic time? So COVID-19 has affected aquatic physiotherapy services to the maximum. There has been some ambiguity as to whether aquatherapy should be provided or not. Ultimately, answering this question depends on our national regulations to contain and control the pandemic. Whatever national regulations has been given by the India or globally, we keep all these guidelines and the restrictions into our mind, and then we start planning how to go about aquatherapy. Now there are many governing bodies in throughout the world where people are forming the guidelines to start aquatic therapy in COVID-19. So before I present the guidelines, let me touch the very important point, that is about water hygiene, which is with or without COVID-19 need to be maintained. This is very, very important part because it is through the water only we can get affected. So first we should know what do you mean by water hygiene in aquatic therapy, especially in aqua rehab. Now here, when we are talking about water hygiene, I am talking about the normal swimming pool or the aquatic pool, which we are using for treating patient. A swimming pool can quickly becomes very infectious because of the presence of bacterial food. Now, what kind of bacterial food we can give it in the swimming pool is skin flakes, fatty oils, and hairs from the users, urine and sweat. All these can be the bacterial food for the bacteria. And another important thing is the water temperature, which is always around, especially in the aquatic pool, the therapeutic pool, where the water is temperature is around 20 to 35 degrees centigrade, and it is an excellent environment for bacteria to procreate. And many bacteria thrive in an aqueous environment. So in the healthcare pools, visitors are again, they are also very susceptible to infections uh, because of maybe because of the recent surgery or due to poor physical condition, or they might even be carrier of multi-resistant bacteria because of recent hospitalization. So, so water hygiene is very important, not only in the public pool, but also in the rehab pools. The only safe agent to kill aqueous bacteria and viruses, according to current technology, is chlorine. We use chlorine for each and everything in the to purify the water, as we all know. Now, why chlorine? Chlorine actively kills or suppresses the bacteria in the pool, and sometimes we get strong smell from the pool, and often our eyes hurt. When we go into the pool, what we see is we get a very strong smell and our eye starts burning. When we submerge our head inside the water, our eye starts burning, and this is due to the mm, bound chlorines which is present in the water, or we call it as chloramines. It occurs when chlorine binds to contaminants. So if if there is a smelly pool, the pool smell is too strong, that means water is contaminated. If chlorine has been added free, generally we use free chlorine into the water. So if chlorine has been added to the pool, and but we can't measure the free chlorine and it smells, eyes hurts, that means there is a real risk the water has become unhealthy. So we need to take care of the water first. Okay, there are other solutions are also available nowadays in the market, like ozone, UV rays, but these are not suited for professional use. Still, it is widely practiced. Chlorine is added to the water. Okay. Now, the safe levels given by the global governing bodies uh, for the chlorine to be used or the levels to be maintained for the safe pool water is free chlorine level should be lower than 1.5 milligram per liter. And free chlorine, it is the measure of the capacity of water to disinfect itself. If free chlorine is present in the water and it is not bind to any bacteria, or there are no bound chlorines present in the water, that means water is disinfected. And if the bound chlorine level, it is the measure of contamination of the water. If it is higher than 2 milligram per liter, the water has possibly become biologically active. So we need to check regularly, and we have to see, we have to maintain the free chlorine level up to 1.5 milligram per liter, and bound chlorine level should not exceed higher than 2 milligram per liter. That means water is safe to use, and the pH should be between 6.8 to 7.8. It should be slightly basic so that acidic medium encourages the level of bound chlorine. Now, these are the various governing bodies throughout the world who have given or who have proposed the guidelines on aquatic therapy. Now, first one is the CDC. I have taken only 4, which are the most prominent ones in aquatic therapy. First one is CDC. CDC is Center for Disease Control USA, ITAF, International Aquatic Therapy Federation, and ATACP is Aquatic Therapy Association of Chartered Physiotherapists. APA is Australian Physiotherapy Association. All these governing bodies have made some guidelines for aquatic therapy to start during COVID. Now, other 3, all the ITAF, ATA, CP, and APA are all relying on the information released by Center for Disease Control USA. Now, Center for Disease, most of the guidelines are based on the objective of patient screening, how we should screen a patient during COVID time, whether we can give hands-on or hands-off therapy, or patient, what should be the patient is to therapist ratio inside the water pool, and how can we control the infection and prevent, and what are the prevention guidelines we must follow, and what should be the pool hygiene, how we should maintain the pool hygiene, what should be the ventilation around the pool area, and what is the recommended chlorine concentration in the pool water, whether it should be the same before the COVID, or during the COVID we should increase more chlorine. So all these objectives, keeping it into mind, people have, all the different governing bodies have made the guidelines. Now, the CDC, the Center for Disease Control, they have published just a few months back, they have published that there is no evidence that COVID-19 can spread to people through water used in pools, hot tubs, or water playgrounds. Proper operation and disinfection of pools, hot tubs, and water playgrounds should kill the virus that causes COVID-19. Based on this statement, other governing bodies throughout the globe started forming their own aquatic therapy rules. But Center of Disease Control have not given, they have published that there is no evidence that COVID-19 can spread to people through water. So only one thing which we have to maintain during this time is the proper operation and disinfection of the pool. The social distancing remains the same as we maintain outside the pool. Inside the pool also, we must maintain the social distance. Then still it is under the study that inactivation time of the virus that causes COVID-19 is still, it is not known. Next is IATF, that is International Aquatic Therapy Federation, that is the most widely, it's a most widely used or association or a federation. They have given extensive guidelines on aquatic therapy sessions in the pool. According to them, a COVID-19 triage should be performed if if there is any increased risk of COVID-19, then there should not be any face-to-face treatment. If there is no risk of COVID-19, then face-to-face treatment can be considered. And face-to-face treatment can be hands-off or hands-on. Hands-off means patient can sit near the pool and he can give the instruction. If patient is capable to maintain balance inside the pool, patient can go inside the pool and do the exercise. Therapist can sit over the pool and can give the directions. Hands-on, when patient is not able to go inside the pool and do the exercise, needs assistance, then the therapist has to go inside the pool and give the therapy. That is hands-on. And only a physiotherapist has to decide if face-to-face aquatic therapy is necessary to prevent irreversible decline. And it should be based on the normal screening procedures, balance, etc. If patient does not require hands-on, patient can maintain the social distancing and can give the therapy. The social distancing norms remains the same. It is 6 feet. Our Indian rule also is 6 feet. There also in outside, throughout the world, it is 6 feet. So 6 feet distance should be maintained. Hands-on treatment, if it is necessary, therapists should consider to wear personal protective equipments and should go inside the pool. Pool staff should be limited in order to reduce the amount of social or therapeutic contacts. And patient and therapist should perform a full body and hair rinse before therapy for about 60 seconds. This is very important. This is just like that of hand washing technique. This helps to decrease the disinfection byproducts in the pool, which eases to maintain an adequate level of free chlorine. Now, very important thing is how much chlorine should be added in the pool to maintain the pool hygiene. That is, free chlorine should be 1.2 milligram per liter and pH should be maintained at 7.2. This is very, very important because it has been proven that the free chlorine, if its amount is 1.2 milligram per liter, it kills the bacteria inside the pool. 99.9% bacteria are reduced in 30 seconds. So this free chlorine level should be maintained when we are giving aqua therapy inside in the therapeutic pool. Another very important thing which we need to maintain is the air quality. The air quality, the ventilation around the pool. Generally, the therapeutic pools are closed rooms because to maintain the temperature of the pool between 30 to 35 degrees centigrade. And if we keep it open, the temperature you can't regulate. So, but during these COVID times, we need to maintain the air quality. Okay, we have to maintain the ventilation of the pool. Next is Aquatic Therapy Association for Chartered Physiotherapists. The guidelines proposed by the Chartered Physiotherapists Association, Chartered Physiotherapists of UK, have in the same line of the ATAF, ITAF, that is International Aquatic Therapy Federation. Both of them, they have their guidelines are more or less same. What they have given more emphasis on about the use of mask. Rest everything remains the same in ATA CP2. All patients must be screened prior to the treatment. And if treatment can be directed by the aquatic physiotherapist on pool side, Social distancing is very important. It is recommended to minimize the risk of viral spread. For those patients who require assistance within the water from the aquatic physiotherapist, a risk-benefit analysis should be performed to decide whether hands-on treatment is appropriate. And the patient number should ideally be 1:1. If the hydrotherapy pool is large enough for more patients, ensure 2-meter social distancing can be maintained within the pool as well as throughout the reception, waiting room area, changing area, showers, and poolside. All staff and patient entering the pool must comply with infection prevention and control guidance. It is recommended all staff and patient wash their hands with soap as per the guidance, and also full body wash with soap and water prior to putting on their swimwear just before entering the pool. The most important thing what they have proposed in their guideline is, if either the patient or the therapist are to require to submerge in the water, their wearing a face mask is not possible. So the mask should be removed for the submersion and stored on the poolside in a disposable bag. As soon as their session gets over, they have to take out their mask and they have to wear the mask. After each treatment, all areas which the patient has come into contact must be cleaned and disinfected, especially the handrails, benches, shower beds, and walking aids. All these areas should be disinfected. Mechanical ventilation should be maintained and it should operate at 100% fresh air with no recirculation. This is what it has been proposed by IATF also. So 100% fresh air is recommended in all the therapeutic pools. A free chlorine level, again, ATA-CP also, they recommended 1.5 milligram per liter to get at least 99.9% inactivation in 30 seconds in pool water with pH between 7 to 7.2. Next is Australian Physiotherapy, Aquatic Therapy Association. They have also given an extensive guidelines to their all the states of Australia. According to them, they have proposed planning. All the states will have a staged roadmap to refer for the necessary process required to reopen or to continue. They have to prepare a screening or risk tool using readily available information around symptoms. Then everybody need to discuss screening and triage of clients with treating physiotherapist, frequent regular testing and interpreting of pool water of pH and disinfectant levels should be checked 4-hourly, or if automated systems once daily, and documenting digital reading. Pool water pH should be maintained to 7.2. Conduct regular microbiological test of pool area as outlined by the state guidelines. Then consider the different risk profiles of your clients and all the activities. Consider risk of aerosol generating procedures, that is low intensity standing exercise versus high intensity cardiovascular exercise are need to be considered inside the water. If we want to recommend physiotherapy for the cardiovascular conditioning exercise inside the pool, then these governing bodies, they recommended it should not be performed in the water initially, because that increases the flow of respiration, and the therapist may get infected if the patient is affected by corona. So high aerobic activities are not recommended inside the pool during this time. Wherever possible, ensure appropriate physical distancing between people in the facility as advised. Another interesting guideline proposed by APA is bringing caregivers into the pool to provide physiotherapy support if they know how to swim. This could be an option in physiotherapy practice, using a family member or usual support worker to perform the aquatic activity, allowing physiotherapists to maintain physical distancing. And here also we need to consider the safety of all caregivers. Risk for airborne droplets, coughed, sneezed, or in some other way expelled on the breath of a person with COVID-19 are thought to be a risk to others. So we need to take care of this inside the pool. Another important thing which we have to consider here is the same like other governing bodies, risk for equipment surfaces in and around the pool or the changing room has to be maintained. Still, as we know, the virus is mutating day by day, the new symptoms are appearing. So guidelines are also not fixed. All the guideline mentions are not about the patient recovering from COVID-19 infection. Everything depends on the state of knowledge available till date. Whatever we have I have discussed today, this is proposed by based on the symptoms they have seen and how the virus till now it has reacted and how the patient symptoms are evolved. So knowledge and guidelines like the WHO guidelines will change in time and will be updated whenever necessary. Patient recovering from a COVID-19 infection may show a wide array of complications requiring a rehabilitation pathway, which may include aquatic therapy. So we have to consider, we should follow all the guidelines and start giving aquatic therapy. Until research indicates the COVID-19 recovery trajectory includes unique symptoms, um, the International Aquatic Therapy Federation advocates impairment-directed best practice interventions. What is impairment-directed best practice interventions? Any impairment, that is muscle weakness or a reduced endurance, can be treated inside the water, not the COVID. Okay, any symptoms which can lead to, or any symptoms which is having, the patient is having any symptoms of weakness or any neuromuscular conditions where they require aquatic therapy, impairment based aquatic therapy can be practiced inside the pool. Thank you so much.
Thank you, madam. It was a wonderful presentation. So regarding actually different guidelines, and maybe we have also clearly understood that how we have to proceed as far as aquatic therapy is concerned. We have a question from the audience, madam. So the question is, why the intense aerobic training is avoided according to IATF?
Actually, the respiratory load increases when we put the patient inside the water. Okay, and aerobic activity, it increases the rate of respiration. When the rate of respiration increases, and if the person is having any COVID symptoms or asymptomatic, may result, it may increase because social distancing can't be maintained inside, the patient will have, or the symptoms will aggravate when the patient is inside the pool. So that's what they said, that intense aerobic training cannot be given inside the pool during the COVID time.
Okay. Thank you very much, madam. And
Yes.
I once
Thank you,
again
sir.
thank you for
Rajan sir,
yes, sir.
please ask the participant to send their email ID so that we can send the certificates.
Yes, sir.
You have to give certificate, na?
Sir, all their emails are available, sir, because they have registered now, sir.
Okay, right, sir. Okay.
Uh, Thank you, madam, for accepting our
Thank you,
invitation
sir.
and
Thank you very
being
much, sir.
with us. And yeah, it was very good for all of the participants to know, because, like, I think aquatic therapy is picking up in India, and
Yes, sir.
maybe like even aquatic therapy itself is very new to a lot of people, and probably like this is a very challenging situation, and you have given a clear cut idea about how to proceed, and thank you very much, madam. And now we go to the next speaker. The next speaker for today is Dr. Pallav Bhatnagar. So, welcome, sir, for the first national reference of Indian Association of Physiotherapists. Uh, and he is the principal bar HOD of Geetanjali College of Physiotherapy, Geetanjali University, Udaipur, Rajasthan. And he is clinically dedicated for practicing respiratory integration with movement sciences. And actually, his topic for today is scope of breathwork training as a physiotherapeutic tool in post-COVID-19 scenario. So as I told you, like he's working on that particular area, so he'd be the right person to tell us, like after COVID, like how this is going to help us. Yes, sir. Welcome, sir, and the platform is yours. You can take over, sir. Thank you.
Thank you very much, sir. Good morning, sir. Good morning,
Good
one.
morning, Pallav. Good morning. God bless you.
Good morning, sir. Blessings.
Thank you. God bless you, dear. Good or best wishes.
Thank you very much, sir. My topic for the talk is scope of breathwork training as a physiotherapeutic tool in post-COVID-19 scenario. Now, the entire talk will be divided into two objectives. First is I'll be introducing the breathwork training concept, which is blended with physiotherapy, and what we are expecting post-COVID scenario, and how to incorporate certain breathwork training tools into routine physiotherapy workup. Normally, I always start this topic of breathing as we are cultures of shallow breathers. So our modern society has almost forgot the art of breathing. On the onset, I would like to produce my sincere gratitude and thanks to the Indian Association of Physiotherapy, South Branch, for giving me this opportunity to present whatever thing I'm doing in my daily practice. And a special thanks to Dr. Rajan Sambal sir and to my beloved teacher, Professor C.K. Senthil Kumar sir. Just a few words about my beloved teacher, Professor C.K. Senthil Kumar sir. I would never forget to thank him, because whatever I am there today is because of Senthil sir. And to Dr. K. Annamalai sir, he's a stalwart clinician, and most of my respiratory practices are definitely influenced by his work. There are some famous personalities which are inspiring my clinical practices, and the entire breathwork, what I have blended with physiotherapy part, is the sole understanding from the work of Professor Ida Pauline Rolfe. She needs no introduction to physiotherapy world. And Buckminster Fuller, he was an American architect who has given the concept of dominion, structural tensegrity, which we are using now to understand the collagen tissue tensegrity principles into hands-on training. The next person who has definitely influenced my practice is Thomas Mayers. Again, he does not need any introduction. He has given a total new definition to anatomy, body structure, as well as function. And Moshe Feldenkeris, again, movement science which has been evolved through breathwork was the sole work of Moshe Feldenkeris. So he coined a word called awareness with movement. And that's the thing I see the foundation of breathwork training. The cardiopulmonary experts, Elizabeth Dean and Donna Frankfurter, and last but not the least, Thomas Hanna, the person who has coined the term sensory amnesia. So sensory motor amnesia is something which really, as a therapist, I am practicing past more than 8 years. And I propose to the stakeholders in physiotherapy to please look into this area and incorporate this particular topic and subject into the BPT curriculum. So going with the theme of the conference, post-COVID-19 scenario, I see it is an era of evolving possibilities in physiotherapy. Lot of things will come to the physiotherapy world, and it's a time to come back and to improve the physiotherapeutic things we are delivering to the society. Before starting this talk, the entire concept between the anxiety versus fear need to be understood. So according to the Moshe Feldenkeris, anxiety is directly proportional to muscle tension. As a therapist, my work is to do muscle work. My exercises are prescribed for the muscles designed for its biomechanical effectiveness and efficiency. So anxiety is directly proportional to muscle tension. More anxious the person, more muscle tension, and it is happening at a subconscious level. So it is so subtle that we don't know, we are not aware. We are the victim of anxiety, and why suddenly there is a transformation from a healthy body to a sufferer body. And we call it age. So age is a number, it has nothing to do with stiffness. So anxiety is directly proportional to muscle tension. So whatever we do, we need to address muscle tension, because the muscle which is out of its optimal tension can neither contract or relax. And difference between the anxiety and fear is happening at a higher level. It is happening at central nervous system, which is again directly connected to endocrinal system, and it is having a feed forward and feed backward mechanisms that we'll be seeing in breathwork. Post-COVID, definitely according to Dr. Stephen Porges, again a name which does not require any introduction, the propagator of polyvagal theory. So we have a lot of branches of vagal nerve, ventral branch, dorsal branch. So there are total 3 states in which persons will be responding. The first is immobilization state, which gives we are freezed, we feel helpless, pathetic, and we are depressed. And the second state in which people may react to post-COVID scenario is they will run from all the dangers. So it's a coping mechanism, survival of the fittest, Darwinian theory. So mobilization state is different from immobilization state. But the balance of immobilization state and mobilization state is called as social engagement. So it's a new term which is being coined now. And when a person is in a state of social engagement, they feel calm, relaxed, and connected. So a lot of anxiety and fear cycles are there in the society. And as a physiotherapist, definitely we are looking forward to more and more socially engaged people, those who are coming into our clinical practice. So the objective is breathwork training, the principles and ideology behind. I'll be going through it. And at the end, I'll be briefly discussing the clinical approach, the assessment and intervention, what I am doing for breathwork sessions. So the concept is, according to Hensai, the work, he has worked a lot on endocrinology that leads to formulation of concept of stress. So he coined a concept called disease of adaptation. So in our lifetime, from birth to death, we have a lot of diseases which we have adapted. And he has coined it under general adaptation syndrome, GAS. And the most important principle, what he has stated is that psychological events are more important as physiological events in determination of health or illness. Normally, as a therapist, I was more looking into the initial phases of physiotherapy practice with body structure and body function, the ICF concept, what we have read. Later on, I came to understand the body structure is different from body function, and function involves physiology and psychology. And psychology is something which is superseding the both functions. So at the end of the day, now research has also proved, and we can say it is the function that defines structure. It is not the anatomy which defines physiology, it is reverse way around. And the another concept of Hensley work was the concept of interoception. So what we from inside of ourselves can do to reduce the effect of stress is tremendous. So the approach to reduce the stress of day-to-day life is not exteroceptive. It is not the patient is entering into physiotherapy department and offering him some routine exercises, or I'm prescribing him you should do this. So it's a mechanical idea of exercises, doing a robotic repetitions of all movements. Hence, Aili says, whatever action we do with the muscle work has to be connected with the mind. Each and every single cell should reach to the mind when the person is doing the exercises. And it is the same concept of BKS Iyengar Yoga also. And the third premise is controlling attitude. The way we control our lives, which is called as self-responsibility. So behavioral modification therapy also kicks in the work of breathwork training, the world of breathwork training. The nutshell is we should always give our patient and client the internal ability of self-control so that he should not feel victim to the misery part of the society. So life is largely a process of adaptation to circumstances in which we exist. And hence Aili quoted, the secret of health and happiness lies in successful adjustments to the ever-changing condition on this globe. So today we are facing a pandemic situation which nobody has seen before. So it's a new thing. Everyone is fighting against it. So the penalties of failure in this great process of adaptation are disease and unhappiness. So for a person who fails to adjust to the ever-changing needs of the globe, the penalty is disease and unhappiness. So everyday existence, there is another type of evolutionary adaptation which takes place. The stress is essentially the rate of wear and tear in the body. As a therapist, the physical wear and tear, what we are seeing, are nothing, they are the responses to stress. And it is always a non-specific response to the body, and it is against a demand. So there is no classical sign and symptoms involved most of the time. So it is non-specific. And it is neither good or bad, it is neutral according to Hensley. And aging is the reflection of lifetime wear and tear we have taken and accumulated. There is a new concept which is evolving where we are challenging the theories of aging. So in the left hand side, this pyramid, I'll just take the pointer. Yeah. The hierarchical approach which has to be adopted in a breathwork training session or in a respiratory physiotherapy session is the spiritual need of the patient, followed by emotional need of the patient, then the psychological needs, and the last is the physical need. So it is a total inverse pyramid concept to what we are following today. So social behavioral model, Darwinian says survival of the fittest. So there are two instincts, survival instinct or withdrawal instinct. So post-COVID, we'll be seeing our patients into two different area of behavioral model. Survival instinct means, yes, patient is committed and he will come back to the restorative practice of the social engagement. I'll just give you a simple example. A person who is having a severe ankle sprain cannot walk even antalgic gait. He is not able to walk only. Suppose he is walking on the road and suddenly there is a dog which is running and barking behind him. What he will do? If he wants to survive, he will definitely run with the sprained ankle, which he would have never run in the absence of this trigger. So this is the meaning of survival instinct. If there is no other alternative, we will perform functions. In my practice, patients, they say, sir, yesterday there were guests in my house, and throughout the day I was standing, I was cooking food and I was serving them. Whereas the patient cannot stand for 5 to 10 minutes because of acute prolapse disc. So the environment counts a lot, and the withdrawal instinct is to become a prey, feel disengaged, and most of the things they call it flesh and tissue thorn concept of Ida Pauline Rolfe. Problem of digitally observed modern world. I'll be discussing this topic through respiratory point of view. I won't go through the biomechanical concept of mechanical world. So digitally observed modern world will give two emerging added problems into magnified view, that is sensory motor amnesia and the gradual surrender, which is called as atrophy. And this I'm talking of sensory motor atrophy. So the concept is sensory motor coupling. Why breathworks are a challenge and underlooked portion of the society? Because the common five senses, we call it gross senses, they are easily available to us. We don't have to be more cognitive, more alert. We are easily exposed to the taste, touch, the sight, the smell, and the hearing. We don't need to give additional effort for these senses. Whereas when a person enters into the breathing techniques, it requires a focused attention. So it's a totally reverse approach. So fine proprioceptions are required in order to be into the world of breathwork. So I think this is one of the challenge a therapist will face with an anxious and a depressed person when he or she will be giving the breathwork training. Discussing the first objective, sensory motor amnesia, this is nothing, it is called as habituated forgetfulness. I don't know that I don't know. So SMA was coined by Thomas Hanna, and it is an inefficient pattern of muscular activation that are so habitual that we can't sense or control them. So we don't know which portion of the muscle is not connected sensory to the central nervous system, and the portion of the muscle which is not connected to the central nervous system, because there is an amnesia, the engram or the neural signatures cannot be recalled. So the muscle which is disconnected neither can contract fully nor relax fully. So sensory motor amnesia has nothing to do with the age. Again and again, I am telling, aging is a myth. One of the fundamental cause of malfunctions of bodily functions we believe to be age, but it is not age. Putting this sensory motor amnesia concept to the respiratory diaphragm, the main principal muscle of breathing, the diaphragmatic amnesia is a separate world. It's an ocean world. It's an umbrella term. But normally, as a breathwork training session in physiotherapy, we should know a normal diaphragmatic excursion should be 3 to 5 centimeters. And if the person is well conditioned, the diaphragmatic excursion may go for 7 to 8 centimeter. It's a very good outcome tool which can be documented through radiographic or sonographic evidence, both way. So the stiffness, aches and pains, what we experience in our body can be explained through sensory motor amnesia concept. That is, the stiffness, what we believe to be a part of aging is not actually aging. It is slow and moving so subtle that we believe it is a aging process. Body lose an internal sensory awareness, thereby ability to fully control and relax the muscle. So it's a vicious cycle. So we can see the bullet starting with the color in green. Biological tissue tightens up in an event of either stress, trauma, or injury. So stress can be physical, it can be mental, it can be emotional, it can be spiritual, blah, blah, blah. And the physical trauma, what we see in our day-to-day practice, is also a part of biological tissue tightness, aches, and pain. If the sensory motor system is intact, the muscle tension is reversible. So this is a good news. People, those who are socially engaged, their neural states are well balanced. They respond positively to the event of stress. It can be a sudden demise of a family person, loss of a near one, financial loss, huge financial loss, it can be a job insecurity, XYZ. But the person, if he's having good neural state, that is social engagement, the muscle tension is reversible. So anxiety won't build up. So if anxiety will build up, I told you anxiety is directly proportional to muscle tension. Now, what happens as infant? He or she first develops sensory motor awareness and control. That's the developmental milestones of a baby. So neurodynamic theory, that is also accepted in the latest theory which has come into existence. And once the infant develop the sensory motor awareness and a motor control and motor learning, they shift out attention to the external world. The kid is exposed to digital world, the mobiles, the laptops, cartoon TVs, etc. So the introception, which is required for maturation of central nervous system, is now being shifted to external world, which is another problem statement. Right? The human baby is a unique example of immature central nervous system at birth, highly immature central nervous system at birth. During the lifetime, this central nervous system gets mature by the age of 5 to 8 years old. So the idea of society was a gradual surrender. What I mean by that second objective was surrendering the life function bit by bit. That is the atrophy. So there is an idea of adult and kid. The moment I talk about kid, we have a visualized picture of a kid jumping, howling, running around, playing. And the moment we say adult, we have a visual picture of a old man leaning with a walking age. So what are the preferences difference? Kids usually prefer to run, adults they prefer to walk. Kids they climb stairs, adults always use elevators. Kids scoot under bushes and adults prefer to go around them. Kids stand on their heads and adults are most of the times are sitting on their bottoms. This COVID-19 pandemic has given a new definition to sitting is a new smoking. Kids they roll on the ground, but adults they turn like a log. So segmental rolling versus log rolling concept. And kids prefer to jump up and down, and the idea of an adult to jump is shrugging shoulder up and down. That's it. Kids they prefer to laugh with joy, and adults are having smiles with restraints, lot of restraints. The kids are exuberant, and the adults are very careful. At the end, kids requires fun, but the adults prefer security. So why this slide I have kept is the idea of the modern society is to become an adult. It means we should cease to do the activity what we do like a kid. That's the definition of the adult of this modern society. Being adult, I cannot do the things which kids are doing. So as soon as we stop doing this function, there is a principle called as use it or lose it. So we lose them. And the brain is highly adaptive. Neural plasticity, the fluid plasticity and the vascular liquid plasticity. So brain does not recognize what is good, what is bad. It is the matter of exposure. Whatever things are exposed introceptively and the extroceptively, brain will adapt to it. That is the disease of adaptation, hence highly. So certain actions are no longer part of behavioral inventory. So when we are not repeating them, our brain forgets it. And day-to-day sensory motor interactions fade away. So a study says when we take birth, our central nervous system is having a lot of coded genetic behaviors in it. And up to the age of 5 or 6 years, if we are using them, we are retaining them, otherwise we are losing them. And the result is sensory motor amnesia. So this is whole about the sensory motor amnesia. Sedentary lifestyle is multiplying multifold sensory motor amnesia. So age-associated declines are not universal and inevitable. Some aspect of the performance do not decline. Not all neurons atrophy. Not all transmitter system decline. So degree of neuronal plasticity is retained in the aged nervous system also. So research has proved it. At any given point of age, skeletal muscle is trainable. Fortunately, this is a good news. Sensory motor amnesia can be treated. So there are three ways to approach to the problem. The first is drug therapy, of course, which is not the physiotherapy domain. The next is behavioral retraining and the preservation of physical activity. The last two bullets are our domain. And the best way we can approach this is a new way of prescribing it. So the entire concept is called as MBSR, mindful based stress relaxation. In our practice, we say the same exercise in terms of strength might be acceptable on one day, but not on the next. Patient says, sir, yesterday also I did the same exercise, same number of repetition, and I was feeling quite okay. But today when I did the exercise, I have not changed the number of repetition or the pattern. I'm having a deep ache. So again, it is the state of mind in which the person, the patient is doing the exercise. So as an exercise therapist, as a physiotherapist, the new prescription approach is the body-mind connection. So mindful based stress relaxation. So one may conclude that maintenance of physical fitness through a lifestyle of daily exercises, the advantage is it is inexpensive and safe method. And the entire answer, which is coming under physiotherapy umbrella, is the breathing control, or you can call it as a breathwork training. So what is the need of mindful based stress reduction? So it was developed in 1970s by Professor Dr. John Kabat-Zinn. So when we target the brain with a specific manner, breathwork sessions, some exercises which we expose to the brain opens the gate of chemicals of relaxation. The same concept we have studied as JPMR, Jacobson Progressive Muscular Relaxation. So when we do a series of targeted movement, we become more progressively relaxed. Even American College of Physicians have given MBSR a green light to relieve pain. It's very interesting. And they also classify the somatic exercises under the category of MBSR. So it's a good news for a physiotherapist. The concept of traditional breathing exercises, the wand exercises, what we are doing in our physiotherapy department is a part of inventory of MBSR. So the principle of breathwork training requires to understand there are some restorative state practices. What are the principle? It is a threefold principle: purpose, present moment, and non-judgmentally. These are the three pillars to understand. So restorative state practices are a learning moment for the patient. So the challenges is when the patient enters the physiotherapy domain, a lot of sessions need to be given initially to make the person acquaint with the learning process. And the patient requires to take to the grounding practices of self and unpurposefully in the present moment. So past has gone, we cannot do anything to change the past, and future haven't arrived. Future never, nobody has seen the future. What the best thing we can educate our patient is to live in the present world. So knowing ourself is important so that we don't fall in the same old reactive patterns as we are conditioned to. Now, the theory has come up with the part is the past experiences, previous experiences are stored in central nervous system as neural signatures and engram in form of old reactive patterns. It can be, for example, it can be fragrance of a perfume. So after 10 years also, if the same fragrance I am experiencing, I may correlate with the person whom I have met 10 years before. Simple. Another example, day-to-day life, any particular location, locality, if there is a road traffic accident which I have experienced, whenever in life I will pass through the same locality, I will recall that accident. So these are some old reactive patterns. So restorative state practices is nothing, it is a new definition which says meeting the stressful condition skillfully. We have to meet the stress with the skillful act and science. So Professor Ida Pauline Rolfe has given a beautiful concept which has changed my clinical practice. The concept of preface of the book of Ida Pauline Rolfe says, little thorn in little flesh. Little thorn, okay, in little flesh. If there is a little thorn in the mental attitude, mind, the same will be reflected in the flesh. Movement dysfunction. So mental attitude can be considered as a biological concrete. My perception, my belief system about the problem or the disease is a big hindrance for prognostication in physiotherapy. This is why psychotherapy fails for some people, and but it can create a concept of immobility. But there are people, those who really respond to psychotherapy in clicks. So what we can do to ourselves, nobody knows better than us. So attention is nothing, it is the choice of choosing to be awake. Intention is the choice to do that, and the attitude is a kind of open curiosity that we bring to the present moment. So when we are teaching breathing exercises to the patient, we allow the patient to be more attentive, cut off from the external world, interoception, and we will let him or her know the intention why he or she is doing this exercise. So here comes the importance of patient education. And the attitude is to develop an open curiosity to the present moment, because the experiences which are occurring in the present moment, the breath can change the biological concrete. So breathwork training also says releasing muscle pain is an educational process. Most of the times, we do a lot of therapies in order to combat the pain. But there are a concept which says peripheral input versus centrally organization approach. So those people, those who are suffering with sensory motor amnesia, they lose their ability to release the muscle. Involved central nervous system in just a way that brain can teach us motor control, motor learning. It's like the way we have learned how to ride a bike, how to throw a ball, how to eat with spoon, various activities. It also teaches us how to adapt to the stress. That's why I told it is so subconscious. Stress is occurring at a subconscious level, and we never know the way it is interfering with movement dysfunction is extreme. So it alters posture, gait, and movement. So in sensory motor amnesia, the feedback loop between the brain and the muscles goes into a cruise control or autopilot. So it's a concept where a flight takes off, the pilot has a full control manually. Once attaining a particular altitude, the pilot push the control into a auto control or a robotic mode. So our brain is in a autopilot mode. We are reacting to the old reactive patterns and we are not aware of it. So thus it makes difficult to control these muscles freely. That's a challenge in front of a physiotherapist when a person comes with a upper cross syndrome or a lower cross syndrome, for example. Coming to the last phase of the talk, there is a concept of DAISY, which is being adapted into breathwork training. And this is very close to my heart. DAISY stands for, D stands for, we need to describe the skeletal relationship. So ideally when a person enters for a breathwork session, we take all detailed histories, the traditional part of histories, but the new concept is we take a structural assessment part of it where weighted foot is very important. I'm repeating the foot. Weighted foot is the horoscope of the patient. And we assess the soft tissue patterns that create or hold the patterns in place. Somatic approach, there are reflexes, we call it red light reflex, green light reflex. These reflexes, green helps to keep moving, red freezes us, and there is a trauma reflex, which we have adapted in lifestyle. The strategies, we need to develop a story. So we call it chronological story making. What went wrong from the age of 0 to 5 years old, 5 to 10 years old, 10 to 20 years old, 20 to 30 years old, and so on, whatever may be the age of the patient who has entered for consultancy. After that, once we have developed a strategic plan, what we can work upon is called as we intervene. I stands for intervene, which is the breathwork or a hands-on. So in physiotherapy, our manual myofascial release, manual therapies, PNF respiration, all schools, all thoughts can be very well blended with breathwork training. This is something mind-blowing. The results are so quick. That's what we are doing in our clinical practice. And the last E stands for we need to evaluate, assess, reassess. Without outcome tool, nothing is to be documented. We won't be aware what we are doing. There is a difference between knowing and doing. Knowing is we know the theory, we know the principles exactly how they are, and doing is the skill, how to apply this knowing into clinical practice. So without outcome tool, if we are working, we won't be able to fill the gap between the knowing and doing. So there is a simple test which everybody can apply to the society. This is called as sniff test seated, sniffing, a simple act. So this sniff test is being formulated by Bradley physiotherapy approach, and they are used to test the both diaphragm function, the right diaphragm and the left diaphragm. We check the dominance of the upper chest versus the lower chest patterns with a single test. And how it is done, therapist places the hand, 3 fingers under the xiphoid process and asks the patient to take a quick sniff. A firm outward movement of the abdomen wall should be felt because sniff is an inspiratory maneuver. During inspiration, the abdomen wall has to be pushed because diaphragm is descending down. So in a person where there is an inward drawing of abdomen is a case of classical paradoxical breather or a sensory motor amnesia of a diaphragm. So the sniff test can be used for phrenic nerve injuries after surgery, trauma, carcinoma, post-COVID, neurological herpes zoster poliomyelitis patients. Yes, it is very important tool which can be done in a supine as well as seated and standing position. And most of the infectious condition where I am most working is the infective tuberculosis and pneumonias. The next and the most important outcome tool of breathwork training is Bradcliffe angle. What is this Bradcliffe angle? It is also called as xiphocostal angle. So xiphi sternum and the costal margins. Normally, before treatment, most of the times for the tight chest, for the end-drawn posture, round shoulder posture, forward head neck posture, tight psoas muscle, which is anterior pelvic tilt, increased lumbar lordosis, the concept we find Bradcliffe angle is narrow, and the prognostication is always a wider angle. So how there is a research being done in which there was documentation of this Bradcliffe angle. So week first it was 38 degrees, week second after treatment 57 degrees, and by the end of week 5 it was 70 degrees. So from 38 it has gone to 70 degrees, and week 10 it grows to 76 degrees. So wider the Bradcliffe angle, the better will be the ability of the diaphragm to work, and diaphragm is the principal muscle of respiration. All breathwork training starts with the foot. Now this is important. Even Idarolf has told this. Normally the feet are tattletales and they reveal someone's secret. Feet are the horoscope of a human body. It's the only place which is in connection with this external world. As human being, we are bipedal stance and we walk around with the help of foot. Because we are confined with the shoe throughout the day, we are inviting sensory motor amnesia more and more. So there are 3 types of pain which a person brings to a physiotherapy in the clinic. The first is, of course, the physical trauma pain, which we encounter on day-to-day practices. The second aspect is a hidden or occult emotional trauma pain, which requires skill to assess and evaluate. And the third and most important is the perception of pain, which is escaping the body. Now, there are 3 types of pain. Physical pain, very easy to be experienced. If someone crushes the index finger, we will feel pain. If someone prick us a thorn, yes, we will feel pain. Emotional trauma pain, yes, losing some near one is a very painful process in life. Yes, but the pain which is not perceived as escaping the body is something a question mark. It comes into psychosomatic domain. There are people, those who know how to accommodate the pain but not to escape the pain. And breathwork training helps in this third domain. Most prominent psychotherapists in the world, they have documented there are patients, those who quickly respond to psychotherapy sessions, and there are people, they don't respond to psychotherapy sessions quickly. The people, those who don't respond to psychotherapy sessions are falling under this category because they are having a lack of pain which is perceived escaping from the body. So what feeds helps him? There are 3 important areas. We call it first challenge in physiotherapy practice. So as a breathwork trainer, I always make sure the ankle must be reconstructed. God has constructed it. Humankind has adapted to various stresses, emotions, traumas, and a lot of situations in life. So we need to reconstruct. Reconstruction requires a lot of area to work with the alignment, bony alignment, as well as fascial health. Then we need to free the line of transmission. If the line of force of transmission of the feet are not free, you won't be able to benefit the rest part of the body. So foot versus remaining part of the body is the concept. Feet are the gateway to the mind. The mind body connection is feet, and the structure made sturdy for the job. So the major job of feet is to weight bearing. So normally the subtalar joint is called as waiter's tray. Like a waiter stalwart in a hotel, he is manipulating the tray with a lot of balance and every precision. So if subtalar joint is not free, that precision and that acceptance to the brain is lost in the body. In the end, breathing retraining consists of awareness of faulty breathing pattern, relaxation of the jaws, upper chest, shoulder, and accessory muscles. This is very important. So it's the way we go. It's a flow chart concept. First, we make the person aware of the breathing pattern, whatever breathing pattern they have, faulty, acceptable, not acceptable. We don't give them any positive or negative clue, but we make them aware how they are breathing. And then we help them to relax the jaws, upper chest, shoulder, and accessory muscles. After that, we give emphasis on abdominal and low chest breathing. High chest breathing is again a problematic breathing. And we re-educate a lot of breathing patterns in the third step. Here we intervene as a therapist. And this makes the awareness of normal breathing. When we offer a person what is the normal way of breathing, the rate and rhythms are controlled both at rest during the speech, phonation, vocalization, and the activity. So there is a simple rule in breath world, like in ergonomic world, Google promote a particular rule. We call it 20-20-20 rule. It's an ergonomic tool. After every 20 minutes, take a 20-second break and look 20 feet distance so that the small eye muscles which are engaged in the digital platform can be relieved. And that's why we can recirculate the fascial health, the circulatory health, emotional health, and everything. In breath work, we call it stop, drop, flop. We call it stop, drop, flop. What to stop? Stop and have a chest check. Whether you are breathing from a high chest or from the abdomen. What is required to breathe from the abdomen? When I ask the people to take a deep breath, their idea of deep breath is they inflate themselves and they vertically rise. Now, this is a problem. That's the idea they are having. What to drop? Drop the shoulder, soften them. Don't hold your shoulder against gravity. Allow the trapezius to relax. And what to flop? Relax and loose over remaining part of the body. So this is a kind of concept we always give to the patient to follow outside the physiotherapy clinical practice. Stop, drop, flop. The classical way how to approach, how to design an exercise prescription of breathing is called as I is to P1 is to E is to P2. I is the inspiratory phase, P1 is the end inspiratory hold. You can find P1 here. And the E is the expiratory phase. Normally it is twice the length of the inspiration. And the P2 is the end expiratory hold. Now we have modern approaches as well as yogic approach, traditional approach. I'm not going into detail. But yes, the training of P1, P2 makes the whole difference to the world. So there are a few examples on the right hand side, the cardiac coherence training. When we write 5050 means 5 part of inhalation and 5 part of exhalation. P1 is 0 and P2 is 0. That's the way we write. If we want slow paced breathing, which helps in reduction of blood pressure, so we prescribe the patient 4060 breathing. So 4 part of inhalation, 6 part of exhalation. For a COPD breathing, the ratio is 2060. That relieves shortness of breath. It's tremendous. It's magical. On spot, we can have a result. So 2 part of inhalation, 6 part of exhalation. And last but not the least, the Dr. Andrew Well breathing, which is another wellness and holistic breathing approach. It works dramatically. I have applied in clinical scenario. It is for insomnia. Believe me, fast asleep is 4780. So 4 part of inhalation, 7 part of P1, and the 8th part of expiration, P2 is again 0. So if a person is well trained how to apply these techniques, we can definitely overcome so many psychosomatic issues which are going on. The last concept which I came to know when I was going through these research papers, which simplified my approach, is inspiration requires accommodation, expansion of thoracic cavity, abdominal cavity, and pelvic cavity. This is the third cavity which is underlooked, but inspiration requires these 3 cavity accommodation. If any of the cavity is not accommodating the need of inspiration, we won't have a very good eccentric isometric contraction, which is the lifeline of breathing. So all the muscles which I have stated in the box are the muscles which should be exclusively trained for eccentric activity. That's the crux of the entire Bible, what I'm discussing of breath work. So never deal with these muscles with the other than eccentric phase of muscle training. That's what I want to say. And the rib cage breath work is always considered as functional segments of the rib cage. How we divide them for the breath work purpose: the first 2 neck ribs, followed by 3 chest ribs, followed by 4 abdomen ribs, and the 3 pelvic ribs, because the last 3 ribs gives pelvic accommodation, abdominal accommodation, the chest accommodation, and the dominion effect of the scalene. So the methods are verbal coaching, slow nose breathing pattern, because nose is important, mouth breathers are again problematic. Then mental chanting phrases and humming exercises, which are very important part of breathwork training. Lips should be together, jaw should be relaxed, and breathing should be low and slow. Fast breathing is not designed for human being. HIIT, with all regards and respect, high intensity interval training is not the way of scientific breathing the human body is programmed, and the relaxed stillness as a restorative process. So we say there is a phrase, when in doubt, breathe out. The phrase which has touched my heart is the first breath of life is inhalation, and the last breath of life is exhalation. Manual therapy approach, which are traditional, still plays a very important role in breathwork training. They are the expiratory assist and inspiratory quick stretch and the inspiratory resist techniques. A simple exercise which is as effective as the Midas effect, golden, is the book lift technique, which is later on replaced into clinical practice by 10 kg, 20 kg, up to 50 kgs of weight on the abdominal cavity. So the concept is again Moshe Feldenkrais. We require a lot of principles to go with. In brief, person is interoceptive for this session. How to bring the person into interoception is a different issue. We cannot discuss on this platform because it is elaborative. So once we prepare the person to be into the interoceptive state, we ask the patient to directly activate the diaphragm. So the rest part of the body is silent and still. In this particular pose, we educate the patient to go for a multiple chest checks. So this is called as check test. Whenever we want to check whether I'm breathing normally or not, we should have a high-low hand. So the thoracic hand is called as high hand and the abdominal hand is called as low hand. So normally the low hand should make a movement, high hand should be freeze, it should be still. There should be absolutely nothing happening at the upper chest level. This is another way we help the patient to emotionally open up for a laconical exchange and dialogues during the therapy session. We call it beach pose. So imagine a person who is lying with the hands behind the head. So it helps opening up the chest, lifting up the sternal bone. So the biomechanics portion, the rib pump handle movement and the bucket handle movement. And because the knees are bent, the pelvis is neutral. Neutral pelvis is the seat of physiology of movement science. And the last is the posture, what we educate them for breathwork session. These are all prerequisites of breathwork sessions, is the arms behind. So in this, we are asking the person to just push the hand down towards the floor so that the shoulders are stretched down and chin tuck position is maintained so that the spine is straight. If the spine is not straight, we won't be able to gain the ultimate benefits. At the end, the format of a breathwork session can be summarized as it's a thumb rule approach. There is no deviation in it. First step is to balance the pelvis and the lower limb because these are the ankle should be reconstructed in reference to the pelvis. Next step is to balance the rib cage and the upper limb. So that's the next step. And the third step is to balance the spine. It is not the spine which we will target the first as the traditional approach. In breathwork sessions, we balance pelvis with lower limb, we balance rib cage with upper limb. So rib cage goes with upper limb and lower limb goes with pelvis. So there is a department or a portfolio which is being divided for breathwork sessions. At the end, I am already running a successful foot solution clinic in which the tagline is laziness of the foot will affect the entire human system. Uh, the story of the foot is like a tata and sensory integration of the foot to the rest part of the body is the gateway towards the restoration of health and fitness. This is our clinic in which, because of COVID pandemic, we are facing a delay, but we were supposed to launch an exclusive breathwork clinic in year 2020. At the end, once again, from the bottom of my heart, I would like to thank to each and every single member who has stood on the dais, on the rostral, off the rostral, and backdrop for the preparation of the web friends of Indian Association of Physiotherapy South Chapter, and a special sincere gratitude to Dr. Rajan Sembal sir and beloved teacher Professor C.K. Senthil Kumar sir. Thank you very much for the patience listening.
Thank you, sir. Definitely, it was a new concept and it was a very elaborate presentation. And I think we need to have a separate webinar on this particular topic to understand the whole concept of it. So wonderfully done, sir. We have one question from the audience. The question is, how can we apply the breathing ratio? Can you demonstrate it? So that is the question, sir. So maybe you can answer.
Okay, thank you very much, sir. If I'm not wrong, the intention of asking breathing ratio in our science, it is called as paced technique or pacing techniques, where the inhalation and exhalation, there is a set ratio, as I told, 1:2. So, depending upon the pathology, whether the person is feeling difficulty in breathing in, problem is with the inspiratory capacity or the expiratory capacity, we design a protocol into I is to P1 is to P2, and then we formulate the exercise. For example, when I'm saying high-low breathing, I'll keep my upper hand to the chest, lower hand to the abdominal wall, and then if my intention is 2:6, so 2 part will be inhalation and 6 part will be the exhalation. Now this sounds mechanical because it is a respiratory exercise. When we club it with the breathwork training, again the mind state is meditative, it is a zen mind, and we are interoceptive. And believe me, in ratios, we have gone to the extent where the person is holding the breath for up to 4 minutes, which is a very good level of breath holding capacity. Normally, we say people will die 2.5 minutes to 3 minutes of breath hold. So breathing ratios are used in building the capacity. So we can change or manage the ratios up and down as per the need of the patient. Yes, sir.
Wonderful presentation, Pallav sir. God bless you. Nice.
Thank you very much, sir. I'm all because of you, sir, what I am there today.
No, no, it's all God's grace. So sweet of you. Okay. Nice, nice. Thanks for accepting our invitation, joining with us. Thanks, dear.
Pleasure is all mine, sir. Honor is mine.
Thank you very much, sir.
Thank you, sir.
I think we have a little problem in our next speaker joining us. Maybe so. I request all of you to take a quick 5 minutes refreshment. So probably like the speaker is joining shortly.
Rajan sir,
Yes, sir.
are the speaker here?
Lata madam, sir.
பேசலையா அவங்ககிட்ட?
பேசியாச்சு சார். அவங்களுக்கு ஏதோ கனெக்டிவிட்டி ஏதோ ப்ராப்ளம் இருக்கு. ஸோ நவ் ஷீல் பி ஜாயினிங் சார் ஷார்ட்லி. இவங்க உத்ரா மேடம் பேசிட்டு இருக்காங்க.
Okay, fine.
I'm in contact with her. She's just joining.
Okay, okay.
Sir, you inform them evening what time they have to come back for the panel. This one, no, sir.
Yes, sir. Yes, sir.
You inform these people,
So,
all the participants,
yes,
and put it in the chat box also to join with the link. Okay.
Yes, sir.
There's a different link, no? That time IAP site we are not getting, no? So that link you just give them. Okay.
Yes, sir.
Don't forget.
My dear friends, so today evening by 4 o'clock, we have a panel discussion on online examination in physiotherapy. So it is discussed by the important people in the academic side from various standard legendary universities. So it is going to be really useful for all the academicians who are into the online education and examination. So I request all of you to kindly make use of it. And tomorrow we have quiz competition. So the links will be also be shared to all of you. And in the evening tomorrow, we have an international speaker, Dr. Ulrich Randall, who is going to talk about matrix rhythm therapy by 4 o'clock in the evening. And it will be followed by valedictory section tomorrow. And we have the World Physiotherapy Day celebrations also. So now I will share the link for the joining the evening panel discussion. And you will be getting the links for the further sessions also. Uttara, has the madam joined? Yeah, now she is done. Oh. Yeah, good afternoon, madam.
Good afternoon.
Yes, yes, yes. Welcome, welcome, madam. So thank you very much for accepting our invitation and joining us, madam. So it's our pleasure from IAP South Zone to have you in this platform. And a small introduction about madam. So she's the principal of College of Physiotherapy, Sumandeep Vidyapith University from Gujarat. I think we will now start with the session. We are already late for the session, so we will straight away go to the session, madam. All the platform is yours.
How are you?
Madam, you have to unmute.
I'm Sendil here.
Yes, yes. Now we can hear you.
I'm just sharing the screen.
Ask her to unmute.
Good afternoon.
Madam, good afternoon. How are you?
I'm fine. Thank you.
Okay. My teacher, Rajan sir.
Yes, sir. Yes, sir.
Share.
Is it okay?
Yes, madam. Yes.
Okay.
Yes, yes.
Can we start?
We can start, madam.
Okay. I think at the outset, I would like to thank the organizers of IAP South Zone. Special thanks to Dr. Senthil.
Thank you, madam. Thank you. God bless you, madam.
God bless you too. And today I'm speaking on mental health as it affects physical health and the relevance of it to physiotherapists, especially post COVID-19. To be healthy, one should be healthy in mind, body, and soul. This is possible if one is trained oneself from childhood to handle differences of opinions, stress due to needs not fulfilled, accept quality of existence, etc. Mental, physical, and social health is very important for all individuals. And it is clearly interrelated, interconnected. Mental health, therefore, is said to be more than just absence of mental conditions or disorders. It is said that everyone has some risk of developing a mental health disorder, no matter their age, sex, income, or ethnicity. What is mental health? Mental health is defined as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his society. What are the determinants of mental well-being? These are individual traits like one has to be able to manage one's own thinking process, manage one's sentiments, manage one's reactions, behaviors and interactions with others, manage one's reactions, behavior and interactions with social, cultural, environmental and political factors, with national policies, social protection, living and working conditions, family and societal support. Socio-economic factors play a key role. Social inequalities are at the forefront of inequalities in mental health and well-being. Income inequalities is a fundamental driver of social exclusion. Now, these factors that influence mental health and well-being operate at all levels, at individual level, family, community, and population level. And therefore, a multi-sector approach is required to address the scale of this problem. According to a study, national all India prevalence rates for all mental disorders arrived at are 70.5 in rural, 73 in urban, and 73 rural plus urban per 1,000 population. An estimated 1 in 7 Indians suffered from mental disorders of varying severity in 2017, with depression and anxiety being the commonest according to a study. An estimated 26% of Americans ages 18 and older, about 1 in 4 adults suffers from diagnosable mental disorder in a given year. Many people suffer from more than one mental disorder at a given time. In particular, depressive illnesses tend to co-occur with substance abuse and anxiety disorders. When it comes to countries, India is the most depressed country in the world. According to the WHO, followed by China and the USA. Now, we know that common mental disorders like anxiety disorders, most people in general anxiety disorders experience symptoms like restlessness, physical symptoms, restlessness, fatigue, tense muscles, interrupted sleeps. The next, phobias. There are different types of phobias. Simple phobias, for example, like I am very scared of the lizards. Social phobias, like people have social phobia of exposure to social environments, being at the judgment of others, Agrophobias like situations in which getting away may be difficult, such as being in an elevator or moving train. Phobias are deeply personal and doctors do not know every type. There could be thousands of phobias and might seem unusual to one person, may be a severe problem that dominates daily life for another. Then we have other mental disorder like obsessive compulsive disorders, mood disorders, of which major depression, bipolar disorder, schizophrenia disorders, and post-traumatic stress disorders are the ones. There are lessons which we have learned from previous pandemics, SARS and MERS. The effects included not only high mortality, but also psychological problems for health workers. It was found that in high-risk areas, that is where you are working in a detention area or in an emergency area, 22% exhibited symptoms of post-traumatic stress disorder. In medium risk areas, 13% developed post-traumatic stress disorder. And in general population, 7% were in general population with PTSD. Nurses were stressed more than physicians. Healthcare workers with children reported higher levels of stress than those who did not have children. Reasons were attributed to high stress, to isolation from family, friends, related to job stress, isolation, avoidance from community, and people worrying for their close relatives and families, and losing sleep due to excessive worry, and also physical manifestations like that of headaches. There were complaints from the workers of feelings of detachment, disturbing recollections in dreams, intrusive imagery, and feelings of the trauma recurring. Even after 3 years, the long-term effects you see in China, 40 to 46% were seen to be still suffering from post-traumatic stress disorder. Korean doctor mentioned that we don't say depression, but we say corona blue, meaning everyone was depressed. What is mental health burden of COVID-19? A recent review of psychological sequelae in samples of quarantined people and of healthcare providers may be instructive as per a study, as it revealed numerous emotional outcomes associated with quarantine, some of which persisted after the quarantine was lifted, including stress, depression, irritability, insomnia, fear, confusion, anger, frustration, boredom, and stigma. Specific stressors included greater duration of confinement, difficulty securing medical care and medications, inadequate supplies, resulting financial losses. The mental health burden of COVID-19 is likely to be even more severe than that during the previous outbreaks because of the huge number involved, as coronavirus 2 that emerged in late 2019 in Wuhan, China, presented as a severe acute respiratory disease named COVID-19. The spread was rapid to 216 countries across the globe in a short time, and WHO declared it as pandemic on 11th March 2020. In 5 months' time, 4.7 million patients were infected and nearly 320,000 died. The rapid transmission was by the asymptomatic carriers. Looking into such rapid, chilling experience, we expect that the effects post-COVID-19 will be more severer. The incidence, the healthcare system was struck with inability to deal with suddenness of this extensive dreadful disease. The effects of this, including symptoms of depression, anxiety, insomnia, and grief, as well as the development of post-traumatic stress disorder have been faced by the healthcare workers. The incidence of anxiety among medical staff is noted to be 23.4%. The incidence of anxiety among female medical staff was higher than the males. Incidence of anxiety among nurses was higher than the doctors. And the PTSD scores were higher among female medical staff compared with the medical staff. An online survey conducted in China looked at immediate psychological responses associated factors during the initial state of COVID-19 epidemic among the general population of China. This is the effects on public. 53.8 rated the psychological impact as moderate or severe. 16.5 reported moderate to severe depressive symptoms. 28.8% reported moderate to severe anxiety symptoms, and 8.1% reported moderate to severe stress level. The mental health issues of sufferers of an epidemic, frontline healthcare workers, and the social and psychological impact on the society at large show notable similarities between past experience of viral diseases and COVID-19. Changes in children's behavior. Some of the common changes in children's behaviors can be difficulties with concentration and attention, changes in eating habits, excessive crying and annoying behavior, increased sadness, depression or worry, unexpected headaches and pain throughout their bodies, changes in or avoiding activities that they enjoy. There were changes in elderly people and with people with disabilities. Family members may expect to witness any of the following: changes in the behavior of older relatives, changes to their sleeping and eating habits, irritating and shouting behaviors, emotional outbursts. Effect on homeless people also could be very large and could exacerbate mental health issues, maintenance of social distance during congregate living, which is difficult in homeless, availability of proper sanitation facilities, which are difficult when you are in homeless, less access to healthcare services, drug addiction enhanced in homeless people, and also effect on people with mental health disorders. Coronavirus eruption is equally responsible for causing fear, depression, anxiety, and other mental health issues among mentally challenged individuals, in addition to the infection. Discrimination, stigmatization, and mental health disorders can increase disease transmission and infection severity among people already dealing with mental health disorders. Also, during COVID-19, stigmatization among the general community and healthcare professional would be very vast. People who have recently recovered may have to exercise social distancing. Now, this could be taken differently by different age groups, therefore creating mental health issues. Health workers can also experience social distancing, changes in behavior of their family members when they are back as from the quarantine. The family members might suspect them to be carriers and therefore enhancing mental health issues. The most prominent symptoms of SARS-CoV infection, of course, was respiratory. However, accumulating evidence highlights involvement of even central nervous system. Fatigue is said to be a highly prevalent symptom in COVID-19, approximately 40% as quoted by studies. For patients with ARDS, we all know prolonged stay in ICU, mostly including prolonged mechanical ventilation, is known to have significant impact on lung function and physical functioning, including loss of muscle mass and function. Neuropathy and or myopathy labeled ICU acquired muscle weakness and emotional well-being. The degree of disability at 7 days of ICU discharge determines the 1-year mortality. and recovery trajectory in critically ill medical and surgical patients who survive 1 or more weeks of mechanical ventilation, including ICU and hospital readmission and specialty use in the first year after ICU discharge. Common symptoms reported 1 year later by ICU survivors, including patients with ARDS, include anxiety, depression, and post-traumatic stress disorder. 31% of family members of ARDS survivors have post-traumatic stress disorder 6 months after patient's discharge. Significant cognitive abnormalities may be present in long-term ARDS survivors, particularly in memory and executive functions. Impairments in cognition appear to be associated with significantly increased anxiety and worse quality of life. Post-intensive care syndrome, PICS, including physical, mental, and cognitive impairment, is highly prevalent in patients after prolonged ventilation, 56% after 12 months of ICU. Mental problems, anxiety, depression, and PTSD can occur even in the family of patients with PICS. The world, however, gives more importance to physical health since this is most obvious of the various domains which include intellectual, emotional, spiritual, and environmental health. Also, the illness shows on the body, indicating unhealthy status. Therefore, physical health is critical for overall well-being. Fitness has following components: physical activity, nutrition and diet, rest and sleep, alcohol and drugs, medical self-care. In fact, at every age, person is required to be physical active, right from childhood to being elderly. Nutrition and diet appropriately need to be consumed. Adequate rest and sleep is required to be fit, and minimum use of alcohol and drugs is supposed to be very, very helpful to remain fit. Also, we could be able to do a self-care medical if it is required. Now, physical inactivity, as we all know, is the fourth leading risk factor for global mortality, attributed to 6% of deaths globally. According to Cook 2007, physical activity reduces the risk of developing breast cancer by up to 75%, cardiovascular and heart disease by up to 49%, diabetes up to 35%, and colorectal cancers by up to 22%. Both the physical and mental health are correlated. The evidence base for the relationship between physical activity and mental well-being is well established. Strong cross effects are found between physical and mental health, even after confounding factors are controlled. The last decade has seen a shift in mental health. There is increased awareness worldwide. The United Nations and World Health Organization have made mental health a priority on their global agenda and have issued guidelines on recognizing and treating psychological distress from COVID-19. As COVID-19 is a novel disease, the rehabilitation needs for patients recovering from COVID-19 are anticipated based on evidence from the general critical care population. Based on this evidence, it is expected that acute interventions for the management of patients with severe and critical COVID-19, including mechanical ventilation, sedation, and or prolonged bed rest, may result in a range of impairments, including but not limited to physical deconditioning, respiratory, swallow, and cognitive and mental health impairments. These symptoms are collectively referred to as post-intensive care syndromes. Older people and patients of all ages with chronic diseases may be most susceptible to its impacts. Patients recovering from severe COVID-19 who did not require admission to an ICU may also experience some degree of these symptoms. Safety concerns for early rehabilitation after the acute hospital settings. The physiotherapists need to be cautious on all these things. Physiotherapists need to consider easily applicable tests. Loss of weight and muscle mass must be assessed and subsequently treated during comprehensive rehabilitation in COVID-19 survivors. The regular exercise training principles that are normally used in patients with chronic lung diseases can be considered in non-infectious COVID-19 survivors. As in regular pulmonary rehabilitation, physiotherapy alone seems insufficient to also address nutritional, emotional, and social treatable traits of COVID-19 survivors in the post-hospitalization ICU phase. Therefore, ensuring access to multidisciplinary rehabilitation where patients can access professionals whose skill set align with their needs. This may include physiotherapists, occupational therapists, speech therapists, mental health and psychosocial providers, and in complex cases, physical and rehabilitation medicine doctors. However, rehabilitation workforce composition may vary by the context and in different parts of the world. Rehabilitation programs should be oriented around the patient's needs and goals and may entail exercises, education and advice on self-management strategies, including for cognition, swallow, and activities of daily living, respiratory techniques such as breathing exercises and other techniques, provision of assistive products, caregiver support and education, peer-to-peer groups, stress management, and home modifications. All these need to be considered. Now, finally, I would like to end saying that environment change has been one of the biggest and most vital challenges of 21st century. In spite of all efforts of the humans could only move a few steps forward. But it seems that during the last few months, consequences of the pandemic have successfully recovered the environment to a large extent. And that should definitely set positive impact on global climate change. Whatever be the cause or origin, the occurrence of COVID-19 has emphasized to improve the mutually effective connection between humans and nature. It was important that we as physiotherapists must look into not only becoming very physical, but also recognizing that several of physical symptoms of several of physical complaints could be rooted in the mental aspects of a person. Therefore, it is important that we, although there are specialists available for looking after mental health, we as physiotherapists also must have knowledge adequate enough to know and handle mental health aspects of people seeking physical advices or coming to us for physiotherapy, especially post COVID-19. Thank you so much for patient hearing. Thank you.
Thank you, madam. So it was a good presentation on how we have to give importance to the psychological aspects. And as a physiotherapist, we really need to know the mental health is very important for the physical health of the person, and what we have to learn from COVID-19 and how we have to go about with all your scientific evidences and statistics. I think you really made the day, madam. Thank you very much for your presentation. And we have not received any questions from the audience. So I think they are very clear about the presentation. And thank you once again, madam. And we expect your cooperation and support to IAP throughout. And thanks once again for the presentation, madam.
Thank you so
Thank you,
much.
madam. Thank you, madam.
Thank you, Senthil. All the best. Thanks a
Okay,
lot.
thank you, madam. Bye, madam. Bye, bye.
So all thank you participants, and we'll see you in the panel discussion in the evening. And thanks for joining IAP South Zone's conference. Thank you.